Hey, how's it going? I'm Aaron. I am a second year at VCU. Today we're going to talk about how to search for reversible causes of PEA arrest, kind of a way to think about it. So thinking early this morning, I want you all in your heads, list the H's and T's, go, until that slide advances. So I don't know about you guys, but I certainly can't do that in 15 seconds. And also a little bit of a trick, you just spent 15 seconds thinking about it instead of searching for it. And yet the H's and T's are still the way that ACLS recommends looking for reversible cause of PEA arrest. It's crazy. Litman et al. In 2014 gave us a different approach. They thought about using QRS early in a code. If it's wide, they felt like that is likely to be a metabolic cause. And if it's narrow, it's more likely to be a mechanical cause. So some of that makes some logical sense, although it's not been substantiated in the evidence necessarily. But we know hyperkalemia, sodium channel toxicity, sodium channel blocker toxicity, both cause wide QRS. So it makes sense that that's the things that you think about. They did recognize that there are some other causes of wide QRS that you have to consider as well. And then narrow, more likely to be mechanical. So your tamponade, pneumothorax, PE, acute MI. Most of those are preload dependent, and so they rationalize giving fluids early, wide open, and then treating the mechanical cause appropriately early on. The problem with this list, though, is that it's essentially the same thing, just in a different format. You still have to think about all of that stuff. Hernandez et al., which was in 2008, used a different approach, which was ultrasound. They came up with the cardiac arrest ultrasound exam protocol. It starts with a cardiac four-chamber view, TTE, ideally during a pulse check, or TEE if you happen to have the provider available to do it. And you can see your PE, hypovolemia, and tamponade right off the bat. So you'll see in the left upper hand corner, that's the normal heart. The right upper, hypovolemia, collapsed LV and RV. Tamponade, you'll have the pericardial effusion. And then PE, you have the dilated right side of the heart. Now, they rationalized if you do that, you don't see any of that stuff, you got the normal heart. The next step is to do the lung view. So in that, you're going to look for your normal lung sliding. If it's absent, you consider pneumothorax. If it's normal, then you start thinking about your other things, the toxicological, hyperkalemia, MI, hypothermia. So with the pneumothorax, seeing the normal lung view, you'll have that good parietal to visceral pleural sliding, comet tails below that. Pneumothorax, you're going to see what we call the barcode sign, and you'll see absence of the comet tail, no sliding of the pleura. So this is a little bit better in my mind than the Litman. You're getting something more actionable, but the problem is you're really just doing the mechanical causes of arrest. The remainder are just kind of thrown at the end. It's an afterthought, and oh, by the way, think about all this other stuff too. So that's kind of why we felt like there should be a better way to approach it, and that's where we came up with this new protocol, which I'm sure you guys can all see it really easy, a few steps, no big deal. So actually it really is only 4 steps. The bottom half of that protocol is really just the ultrasound we've already talked about. So we'll slim it down for you and make it a little bit more palatable. So you start with doing the ACLS, continue doing what you know you have to do, but in particular establish your airway. Then look at QRS, do early QRS-directed pharmacological treatment, and then finally do that ultrasound. Look at the cardiac window, the lung window, then afterwards consider acute ischemia. So I mentioned the airway. I know for all of that, for all of us here, that's kind of automatic at this point. But remember, hypoxemia is one of the causes of arrest, and so getting your supraglottic or endotracheal airway early is correcting one of your H's and T's without thinking about it. Then you look at your QRS. So if it's narrow, like Litman was recommending, give the fluids early. It's probably not going to be harmful. It's something that you can get going right away once you get your access. If you have clinical suspicion for hyperkalemia and it's wide, so you see an AV fistula or you have a history of end-stage renal disease, then you can give the calcium. And then TCA overdose, give the sodium bicarb. And then finally, do the ultrasound. So I mentioned doing ultrasound with wide QRS too, but we talked about mechanicals more likely to be narrow. So why is that? Why look for mechanical causes with a wide QRS? So the reason why is there was a study that came out from Birkenau et al. It was 51 in-hospital cardiac arrest patients. They found that 90% of those patients had a wide QRS, and median was wide in all the causes. So their theory was mechanical cause of arrest may be narrow early, but it will ultimately deteriorate to wide. It wasn't the best study by any stretch. 2/3 of their patient data was somehow missing, and 64% had abnormal EKGs at baseline. But it does give us a little bit of pause in using QRS. The argument that we have is you're considering the TCA overdose and hyperkalemia early. So in summary, continue ACLS, get your airway, look at the QRS, do QRS-targeted pharmacological therapy, then look at your cardiac four-chamber view, look at your lung view, and then finally reevaluate. If you haven't found your cause, look for acute ischemia. Thank you.
Judges?
So that was excellent. It's clearly a very important topic, something that we see very frequently, and thank you for giving us a new and innovative way to approach it.